Whereas our capacity in all those 10 centers which are working is around 500 liver transplants a year. So this is a field which requires a lot of doctors. So all the young guys sitting here and the girls, you should consider hepatobiliary and liver transplantation as your specialty of choice in future. And hepatobiliary and liver transplantation can be two separate fields as well. So if we need 10,000 liver transplants per year, we need much more hepatobiliary surgical work as well on top of those liver transplants. So that's important. The reason I put up this topic was because I feel that liver cancer is one cancer which is very badly treated in our country. The understanding of managing liver cancer is complex and the treatment options are very diverse. They vary from liver resection, liver transplantation, immunotherapy, systemic chemotherapy, microwave ablation, TACE, and everything else. And what is happening just now is that it is the luck of the patient in which clinic he ends up. He would just start getting that treatment. And that's the worst thing about it. So if liver cancer patient ends up in an oncologist clinic, there is very likelihood he will be put on some sort of systemic treatment, regardless of the merit of the treatment. I mean, this is just unfortunate situation we come across every day. If he ends up in a gastroenterology or hepatology clinic, he may just go on either supportive care or sorafenib. If he ends up in a radiology clinic or referred to a radiologist, he is definitely going to have several series of TACEs and microwave ablations. And that is problem in our society, and that's what we look into. That is why we look into this problem. So as far as I understand, most of you are medical students and some of you are PG trainees. My question is, so my question is, what do you think, what should be the best treatment for liver cancer? Simple question. And I give the options, आपने pick कर लेनी है. So liver transplant, liver surgery, immunotherapy, or radiological intervention such as TACE. Which is the best option? Guess कर लें, it doesn't matter. Transplant. And that's a reasonably true answer. Then you have to justify it. So transplant is one option. It's one of the good options. Or
Resection is probably the best if it can be done.
that's the answer. So best answer probably still is for a selected number of patients, as long as they fulfill that criteria, which we'll talk about. The best option probably still is resection if possible. But there are many situations. It's only possible in around 10% of the patients. That's the problem. और मैं वजह बाद में बताऊंगा कि क्यों. And next, best option is transplant. And why resection is better? Because transplant is associated with a donation process. You need a donor. It's a bigger surgery, and you need to put a patient on immunosuppression for life. That's a life-changing event. That's why you prefer doing liver resection if technically possible. Otherwise, you consider them for liver transplantation. And this is the main thing which you need to understand. So these are the two options. Both are surgical options. Both have almost similar survival, which is more than 70% 5-year survival, which is really good survival figure for any cancers for that matter. And all other treatments, so this is a bold statement, all other treatments other than liver resection and liver transplants are palliative. So even if you remember this statement from this talk, probably you may be able to save some lives, especially if you are seeing liver patients in future. So all other treatments other than liver resection, liver transplants are palliative for liver cancer. The only two curative treatments are either liver resection or liver transplant, depending upon the merits. So this is what I just said. So 5-year survival in patients who have a solitary tumor with no portal hypertension. So these are the two conditions. Patient is medically fit, they have a solitary tumor, and they don't have portal hypertension. They are patients for liver resection. And 5 year survival is above 70%. However, patients who have multiple tumors, or if the patient has portal hypertension, because of portal hypertension, you can't do surgical resection. Those are the patients who are potential candidates for liver transplant. And the survivals are same. The only difference is obviously you need a donor and you need to put them on immunotherapy on immunosuppression for the rest of their life. So these are the only curative options. Rest of them are all palliative options. I'm not going to go through all of them, but you should know the names. So TACE is transarterial chemoembolization, very commonly used in Lahore, probably everywhere else in Pakistan to treat liver cancer. But this is a palliative treatment. Unfortunately, patients are not even told that they are undergoing palliative treatment. Uh, Sorafenib is a medical treatment. It's a sort of chemotherapy. It's again used in palliative settings. More recent is transarterial radioembolization, in which they inject some radioactive beads into liver around the tumor, and that the results are better than TACE. And most recently, immunotherapy has been shown to be better than sorafenib. Um, And immunotherapy has also been used in adjuvant settings and has shown better results. But I think that's not really, I just wanted to touch a little bit about it. This is the algorithm. It seems very complex. But as far as liver cancer is concerned, if we want to give curative options, as we discussed, those curative options are transplant and resection. And if it's a single lesion and patient doesn't have portal hypertension, you can put them for resection. If they have more than one lesions and are portal hypertension, they can be considered for transplantations. Patients who don't fall into this category, they are offered rest of the treatments. So just to clear the concept that who are the patients you are going to select for resection and who are the patients suitable for transplantation, you have to consider all these factors. So is the organ transplant service available, or is the donor available for that patient if you are considering transplant? How bad is the cirrhosis of liver? If the cirrhosis is associated with the portal hypertension, as we discussed earlier, then they are not suitable for resection. And but you also have to consider that resection is associated with higher recurrence rates as compared to transplantation. Especially if there are more than one tumor, the chances of recurrence is more than 50%. So that is why you have to consider all these factors while making decisions. Um, you have to decide whether you are offering resection or transplantation, whether that is going to be oncologically appropriate. For example, is there any vascular invasion? What is alpha fetoprotein levels and all that? If you are considering resection, is it technically possible? And how fit is the patient? So these are all the factors you consider when you are making decisions between liver resection and liver transplantation. So this is our checklist in my center. So uh, generally, if platelet count is more than 100 and their bilirubin is normal, enzymes are not too high, and they don't have portal hypertension, we consider these. And in patients with childhood cirrhosis, we consider them for liver section. For portal hypertension, any of those features, they will tell you if patient has portal hypertension or not, or you can do hepatic venous wedge pressure in borderline cases. So, so Professor Saab has asked why portal hypertension is contraindicated for resection. So the problem is that portal hypertension means the liver is very stiff now because of cirrhosis and fibrosis. And the portal venous pressure, because of that portal venous pressure has gone up. it is facing more resistance. And because that also tells you that the liver disease is now in advanced situation. So more stiffer the liver is, more pressure in the portal venous system is, the higher is the risk of patients to decompensate after liver resection from liver failure point of view, and they obviously bleed a lot more. It's difficult to control bleeding in fibrotic liver. So the natural mechanism of liver parenchyma to control the bleeding value or transecting is impaired. So these are the two main reasons that you want to avoid liver resection in portal hypertension. There are people who are doing it. You may find anecdotal papers in which people are doing liver resection in portal hypertension, in child's B and all that. The morbidity and mortality will go up. So it's not that you can't do it, you can do it, but your acceptable morbidity and mortality you will not be able to maintain. So another question from the trainees and students: how much liver we can remove from a normal person, for example? 80%. That's a correct answer. And any other answer? 70% is also a correct answer.
50%.
That's also a correct answer. So it depends on various factors. So if it's a 100% healthy liver, for example, a donor liver, for donors, recommendation is that we should not remove more than 70%. So minimally 30% liver should be left. That's for donors. In certain situations, in cancers, for example, you can go up to 75% of the liver. So 80% is a little bit too high. 75% liver, especially if no previous chemotherapy has been given, is okay. But generally, you prefer that at least 30% liver is left behind for non-cirrhotic liver. For cirrhotic liver in patients with Hep B and Hep C or other conditions causing liver cirrhosis, you at least want to leave at least 40-50% liver behind. So if you are planning liver resection, and even if the patient do not have portal hypertension but has early cirrhosis, you should not attempt to remove more than 40% of the liver. So or 50% of the liver. So at least 50% liver should be left behind. So that's a sort of criteria which we use when we are considering resections. And then there are certain adjuncts which you can use to make liver a little bigger. For example, if you wanted to remove a tumor from a patient whose remaining liver was not adequate, then you can use a technique called portal vein embolization. For example, she's a 65-year-old lady, child-age cirrhosis, no portal hypertension, but the tumor was huge. So we decided to do right TACE and right portal vein embolization. A reason we coupled TACE with portal vein embolization was because I didn't want to leave her for 6 weeks before resection. I thought TACE will take a little, at least to part of necrosis of the tumor while she's waiting for resection. So this was a combination of TACE with right portal vein embolization, and this caused a lot of liver growth on the opposite side, and this is post resection. You see this was a right tricectomy for this patient, and you can see that segment 2 and 3 has grown remarkably in this patient. And so this is post-surgery scan of the same patient. So these are the techniques which you can use to make the remaining liver bigger if it is not big enough for you to perform dissections. ALPS is associated liver partition with portal vein ligation and stage liver resection. There was a procedure which was first time published in 2012. It's a recent procedure. It has been quite effectively used in many cancers, but for HCC with cirrhosis, results are not that great. Morbidity and mortality is very high. So in the initial data, everyone used it for everything. The liver surgeon thought, oh, this is going to be the problem solver for all operations, but actually it didn't prove to be a problem solver for cirrhotic patients in particular. Their morbidity and mortality in ALPS was quite higher as compared to when it was done for other cancers. And then further research showed us that the size of the liver increased with ALPS, but the function of the hepatocyte is not as good. They were immature, poorly functioning hepatocytes, although their number and size has grown. So it doesn't work very well in cirrhotic patients. So that's what ALPS is about. In ALPS, what they did was, because in portal vein embolization you have to wait for 6 weeks for the liver to grow. In ALPS you can do your surgery in 2 weeks. What you do is, in first stage, you divide, if the liver tumor is on the right side, you divide the portal vein on the right side, you do your transection on the proposed transection site, but you don't divide the hepatic artery and hepatic vein. So around 20% oxygenated blood is going through it, but 80% blood is cut off, and the combination of transection and stopping the blood causes huge rapid growth of the normal side of the liver. So this is one of my patient. This is a huge tumor. This is stage 1 of ALPS, in which we divided the. This is clips on the hemlock clips on the right portal vein, and transection is completed. This is huge tumor here. This is stage 2, in which uh, sorry, this is the same stage. After transaction, we put the tumor in the bag, but the hepatic artery and hepatic veins are still flowing, and there's a tumor out in second stage. So point is that if the remnant is not good enough, there are ways around it which you can sometimes use and still consider resection. Now, coming towards liver transplantation. So those patients who are not suitable for liver resection, for example, they had portal hypertension and they had more than one tumor, then you have to consider them for um, liver transplantation. Now, for liver transplantation, everyone would have heard Milan's criteria, because that's going on for about 20 years now. Um, but there have been so many other criteria. I'm not going to go into details, but generally Milan criteria means there are 3 tumors, each one of them up to 3 tumors, each one of them less than 3 centimeters size, and maximum size diameter is not more than 5 centimeters. So that criteria was used for a long time, but then so many other criteria coming up to Toronto, in which they said size doesn't matter as long as the tumor is not poorly differentiated on biopsy. You can perform liver transplant on those patients with more or less similar results for 5-year survival, but they have published recent data for 10 years in which a little bit of difference. But regardless which criteria your center is using, point is that if resection is not possible, the second best option is liver transplantation. And then you have to consider whether your center use any of those criteria if that patient fulfill that criteria.
What is median square? Does it increase the chances of metastasis? That is why it's included.
So all these criterias are just about really number of tumors and sizes of the tumor. So everyone has agreed, if vascular invasion is there, biliary invasion is there, or extrahepatic disease is there, they are absolute contraindication for liver transplant. So that is agreed by everyone. The only controversy is whether it should be 3 tumors you will accept in a liver, or up to maximum 6 or 5 or 4 or 8. In Toronto, these guys, I think they cleverly, their data show that it doesn't matter how many numbers, doesn't matter what is the size of tumor, they would biopsy, and if it is not poorly differentiated cancer, they would transplant. And their 5-year survival was same, slightly inferior in 10-year survival. And now this is actually adopted by many centers, who especially the centers which are doing living donor liver transplants. So vascular invasion, Chima Sahib has pointed out vascular invasion, biliary invasion, extrahepatic disease. These are contraindication for liver transplantation because there is very high chance of recurrence after transplantation. That's the reason. So, I mean, I put this chart up that this went through a lot of evolution, that how many tumors should be in the liver for transplantation. The nutshell is, I think every center should have to decide, okay, which criteria they are going to follow. And generally, if you are generally throughout the world, one principle everyone is following. If you have smaller numbers, you accept broader criteria. If you have higher numbers, you accept narrower criteria, and that's all. AFP is very important. If AFP levels are higher than 4 or 500, the recurrence chances are very high, and that is why recommendation is that if AFP levels are high, you should downgrade those tumors either with TACE or TARE to reduce the chances of recurrence. That's another thing we have to consider. Um, and now, most recently, um, and that's not from future now, so TARE has been used successfully in downgrading those tumors which have vascular invasion or biliary invasion. They were downgraded and were later on either transected or transplanted with similar outcome to patients who didn't have vascular invasion. So this is all. TARE is a new procedure. All the data is now coming up in last 4 or 5 years. That's why I think it's going to change the guidelines in future. I think TARE can be very effectively used, especially in patients who have portal vein tumor thrombosis, because it kills the tumor cells inside portal vein. In this study, they looked into the resected specimens or hepatectomies, जो transplant में हुई वो वाले specimens, and they found that in majority of them there was total tumor necrosis with TARE, and many of them were those patients who had previous vascular invasion. So, what we are talking about so far is that as in liver resection, we use several adjuncts to make liver resection possible. We can use certain adjuncts to make liver transplant possible if it was not fulfilling a standard criteria. Sorry. Yeah, this is another study. They basically use TARE to downgrade tumors for resection and transplantation, especially those patients who have had vascular invasion, and they showed 97, 98, 86, and 86% 1, 3, and 5 year survival in the patient, which is more or less equivalent to standard patients. So this is one of our patient. This patient had right port vein invasion and underwent TARE. You can see there is tumor highlighting here. This is portovenous phase, washed out, and this is post TARE. There is no arterialization, and this patient is now under evaluation for his LFT. His AFP dropped, and he has PET negative disease, and we are considering liver transplant. Now is being investigated for that. So liver cancer, this patient had like liver transplant 5 years ago in Bahria. So you achieve more than 70% 5 year survival in these patients for liver cancer. So please remember, as I said earlier, the treatment of choice is either resection or transplantation, depending upon the merit. Rest of all the treatments are palliative. So if you have to follow ASSLD guidelines. If it's a single tumor and no portal hypertension, you can consider them for resection. If they have portal hypertension or more than one tumor, you should assess them for liver transplantation. If none of them is possible, then you can try using these adjuncts to downgrade them so that they can be considered either for either one of them. If none of that is possible, only then send them for palliative treatments. Thank you. Thank you, sir.
Sir, for very informative talk. Any questions from the audience, please?
ये कमेंट है
Professor Arshad